Elements of this story are from my own clinical practice, but the patient we're about to discuss isn't real. They haven't ever existed. All the images in the slides are images that have been taken from free stock image sites. They're not real patients. This isn't medical advice, and it's most certainly not a medical qualification. So please don't go out and try some of the things that we're going to talk about here on real people. If you already work in clinical practice, stick to your existing scope of practice, but you should know that. You shouldn't have to hear me say it. The year is 2085. And a few years ago, we got rid of our medics in favor of AI. The thing is, an American billionaire has just decided that he doesn't much like the UK anymore, so we lost access. Now that's not great. Fortunately, someone somewhere has decided that a backup plan for that is going to be basically dealing with humans as very complicated embedded applications, because that's more or less what they are. We just forgot to put many options for engineers to connect to identify what's going on. Over the course of this talk, we're going to talk through what happens when a software engineer approaches the way that a patient is debugged, assessed, and managed in the emergency context. If you want to guess along the way, feel free to toot out things on Mastodon, and if you manage to get it right before the end of the talk, find me at Q&A, because I'll have a surprise for you. I want you to meet Lisa. This is Lisa, and Lisa is unconscious. One of the things that we often talk about in emergency medicine in particular, but across most areas of medicine, is whether a patient looks well or looks unwell. It's a skill called an end-of-bedogram, and you get better at it over time. Lisa looks unwell. She looks pale, and she's not responding to us normally. That's not good. I feel like it probably shouldn't take much of a qualification to work that out. That's not what we want patients to look like. So if we think about what we do in software engineering with this kind of patient, or this kind of problem, we have a very systematic way of approaching things like this. We can identify the problem. We find the bug. Then we find what's caused the bug. We work out how to fix it, and we solve the problem. Fundamentally, the way that we approach a patient assessment is going to be more or less exactly the same. It's just a very different context. If you have the skills to be able to decompose a problem, you probably just need the knowledge about how it applies to humans. So let's do just that. Let's identify the problem. How many people in the room are or have been at some point in their life software engineers out of interest? A fair few. I'm going to place a fair bet that most of you will recognize this from at least some point during your educational work. This is the OSI model. It is a way of representing how different applications work across different layers. And the important thing about the OSI model is that in this model, each layer builds on the ones underneath it. So in order to have the application layer, you need your session layer to be working. In order to have your network layer, you need your physical layer to work. If there's a layer 1 failure, nothing at layer 7 is going to work. We actually have something relatively analogous in the way that we approach an emergency patient. It's called our primary survey. And anyone who's done a medical qualification before of some kind, even if it's just an emergency first aid at work course, will probably recognize that terminology. But we do exactly the same thing in principle, whether you're doing emergency first aid at work or working in an A&E. The reason we do it that way is because there's lots and lots of things that can potentially kill you in just a few hours' time. There's not that many things, on the other hand, that can kill you right now. And what we want to find is that all of our underlying layers are still working, so that then we can go and build up to work out whatever else is going on. So our primary survey acts as our requirements gathering, both for triage and management of our patients. And we've got to think systematically for each of these steps, but also integratively, making sure that we're understanding each step that's going on in the context of all the others. We're going to start by looking for catastrophic hemorrhage. If someone is bleeding out so much that they are going to exsanguinate, they're going to lose their blood volume in the next few minutes, we need to do something about that. In the absence of any problems there, we're going to check our airway, make sure that we can get some kind of oxygenation into the lungs. Whether it's happening or not then becomes the next question, looking for whether the patient is breathing. Once you've worked that out, We can have a look at a patient's circulation, whether they're getting blood around their body to the right places. We then look at disability, and disability in this context doesn't mean is the patient in a wheelchair. It means can the patient do the things that they would normally be able to do? And then we move on to the rest of our examination, which, if you've seen this before, you might have heard called expose, examine, lots of different things. So let's apply this to our patient. We can't see any obvious external major bleeding. And by the look of it, our airway is clear, patent, and self-maintained, which is all a very fancy way of saying that they're able to keep a tube open, basically, from their mouth to their lungs. On the other hand, our breathing gives us some pause. Because when we have a look at our breathing, we're seeing that it's quite fast and quite deep. It's got a good regular rhythm to it, but it's fast and deep breathing. And we find radial pulses, so that's the pulse that you've got at your wrist, are fast but weak. There's no difference on either side. You can feel them both there, and they're the same. But they're quite weak and quite fast. Disability-wise, we know that our patient is only pain responsive. So we have a scale of responsiveness we often talk about in emergency medicine. It's the AVP scale, which goes alert, voice, pain, unresponsive. Someone who is truly unresponsive in that scale will respond not at all to even painful stimuli. We know that this patient is responding to painful stimuli, but not when spoken to. And if you're a nerd about this kind of thing in the room, you can probably calculate a GCS from the information I've given you. So this is all concerning. This is a patient who's very unwell. And one of the things that we need to be thinking about right at the top of our list of concerns here is something called shock, which doesn't mean, oh my God. It means an acute circulatory failure where we're not getting the appropriate stuff around to our organs. Our body is a really complex microservices architecture, essentially. But given that we expect it to have a 100% SLA, it's not got a great deal of redundancy to it, which is a little bit unfortunate, really. There's also no distributed tracing. We can't easily work out where something's going wrong. We have to come up with some hypotheses and then test those components of the body to see what's happening. So how do we go about finding the bug? Well, we come up with a differential diagnosis, a list of things which could potentially cause the kind of issues that we're seeing. It's not an extensive list, it's not an exhaustive list. It roughly follows the order of what will kill you first. So this, very helpfully taken from Mind the Gap, which is an excellent resource. Mind the Bleep, which is an excellent resource, is a differential diagnosis for this kind of patient. So we've got our respiratory causes, where we might have someone who's not getting the oxygen in their blood that they need. We might have someone who's had too much carbon dioxide in their blood, and they can't get it off. Or someone who's got carbon monoxide poisoning, which, technically speaking, you could argue is a subcategory of hypoxia, because carbon monoxide replaces the oxygen in your blood, so you can't get appropriate amounts of oxygen in. We've got our perfusion problems. So this might be because someone's tank is empty, they've run out of liquid in their system in their blood. That's hypovolemia. Or it might be because the boiler's broken and isn't pumping correctly. That's cardiogenic shock, where your heart has stopped getting what it needs to get around the rest of your body. It might be raised intracranial pressure. It might be the opposite problem, where our brain is starting to fill up too much, and we're developing problems relating to that. Then we've got our brain causes. So this might be things like intoxication, where someone's taken drugs. It might be epilepsy, where someone's having a seizure and we just don't notice the nature of the seizure. Or it might be encephalopathy, which is a little bit of a cheat in here, because it basically just means something wrong with the brain. But here we're thinking about things like space-occupying lesions in particular, which is where you've got a mass in your brain. And then our final category that we're talking about here is our endocrine and environmental causes. So this is going to be things like hypo or hyperthermia, where someone is too hot or too cold. An acidosis or an alkalosis, where someone has too much acid or alkali in their blood. Or a hypo or hyperglycemia, where they've got something wrong with their blood sugar amount. And there's a few different ways that we can tell the difference between these things. But it's really important that we have the information to work out what could be the problem in order to try and solve it, because we don't have that option of just poking about in the request logs to see what's happened. The first, and arguably the easiest bit of actual monitoring that we can do to look at a number is sticking one of these on someone's finger. This is called a pulse oximeter, and if any of you have ever had any kind of hospitalization, ever been to the emergency department, ever had an ambulance out, you will probably have had someone very quickly and not particularly informedly shove one of these on your finger almost immediately as soon as they walked in the room. Because it's what most of us are trained to do. There's a bit of a question about whether that's a good idea or not, but what this does is it shines a red light through your finger, and using some maths, it works out how much of the blood in your finger has oxygen in it. Because red light reacts differently, or responds differently, to oxygenated blood as compared to deoxygenated blood. And a sensor on the other side captures that and turns it into one of these waveforms, where we can see the amount of oxygen in your blood and also how fast your heart is going. So we can see when we felt earlier that that pulse was fast, we were right. That is a fast pulse. Anything over about 100 we tend to consider fast. That oxygen saturation number, that's okay. We'd expect it to be around that range. I'd be worried if it was dipping below 95, 94. 97 is all right. But it's quite fast, and that's a little bit worrying. The next thing we can do to get a number, we can pop a blood pressure cuff on someone. Give you a bit of a squeeze on the arm, see what those numbers are like. Most people in this room have probably had that done. Hopefully most people in the room have not ever seen a result like that come up on a blood pressure cuff. I realize that's not particularly clear on the screens. That says 84/44. So your 84 is your systolic number, which is the blood pressure when your heart is squishing at most. And the 44 is the diastolic number, where your heart is squishing the least. Unless you work in emergency medicine or critical care or anywhere, you probably won't have seen the number underneath it. That's the MAP, the mean arterial pressure. Most of the time, we don't care about this number particularly because it's pretty arbitrary, unless you are very, very ill. If you're very ill, we start worrying about it. If your MAP is lower than 65, it can be an indicator sometimes that your organs are not being perfused appropriately. So a MAP of 57, I'm starting to worry a little bit. So we've got some of our debugging information. We know something is wrong. We found a bug. We haven't found the cause of the bug, but we found the bug. One of the things that we can do to really easily and simply address this problem is something called autotransfusion, which we really like having fancy words in medicine for things that are actually really simple. When I say autotransfuse, what I mean is get the patient's legs and stick them up in the air. And literally all we're doing here is we're tipping the blood volume of your legs into your chest in order to try and make sure that that blood pressure that's going around your heart is increased. And lo and behold, if we take that blood pressure again, we can see that the blood pressure has gone up. It's still not as high as I'd like it to be. It's still a low blood pressure, but it's a lot higher than it was before. So we know that this patient is fluid responsive. That's also important because it suggests that we might be looking at someone who's not got enough volume in their tank. So let's have a think about what the root cause of that problem might be. Shock is divided into lots of different types, but there's 4 big categories of shock. We talk about hypervolemic shock, which we've talked a little bit about already. We talk about cardiogenic shock, which we talked a little bit about already. We talk about distributive shock, which is where the pipework, which helps to get all of that blood around your body, isn't working correctly. Maybe it's closed off. An obstructive shock, which is where the pipework has literally closed off. This was a pretty bad example because it's a little bit more systemic than that. Without talking about too much about the difference between the individual components, it's kind of hard to differentiate those, and I don't have the time to go into the specifics. But one of the things which can happen to cause a distributive shock is something wrong with the brain, like we talked about earlier. So we need to figure out how we can test this person's brain. One of the easy ways to do that on someone who's not conscious is have a look at their eyes. Now, again, the projectors here are not making this particularly obvious. This will probably be more obvious on the home version. And it's also not a particularly flattering photo of me. But when we look at my eyes here, watch what happens when I shine a light into my eye. The pupil gets smaller. I realize that's really not obvious, actually, in retrospect. There we go. The pupil gets smaller. And if you watch that again, you'll see that it happens on both eyes at the same time. That's because we're sending a signal from our eyes to our brain to allow that to happen. Now, there's loads of those signals. They're really complicated, actually, but you have 12 key nerves which come out of your brain inside your head, which help to regulate lots of different things in your body. We can't test lots of these 12 nerves if you're unconscious particularly easily. There are ways of doing it, but they're not massively easy to do. Shining a light in the eyes is great, but it only tests a few of them. But we might find in a conscious patient that we can do a little bit more. We also find that dependent on the area of the brain where there's a problem, we see different sets of symptoms. So for instance, someone who's got an injury at this part of the brain, the back of the brain, we might find that we have something called dysdiadochokinesia. Remember that thing I said about us having really complicated words for really stupid things? Dysdiadochokinesia is a very fancy way of saying can't screw in a light bulb. Because you can't do a repeated, repetitive movement over and over again that involves fine motor skills. Sometimes you'll see it done as flappy fish as well, which is literally doing that over and over again. On the other hand, someone with a frontal lobe injury towards the front of the brain might have executive function memory deficits. Now, we're talking here about someone who suddenly develops those things. If you have executive function memory deficits in general, speak to someone else, not me. But in this case, our patient's eyes are reacting normally. And for the time being, we're going to say that's as much as we can test. It's not actually, but let's go with that's as much as we can test. So let's think about other parts of our body. Where do we want to go to next? I'm thinking about things which are really important for your body to work. Heart's probably a good place to look. Fortunately, remember how I said we don't have debug tracing? Our heart's a bit of a cheat on that one. You might well know that your heart is a really complicated electrical system. It's one of the most complicated bits of electricity in your body aside from your brain. What actually happens when your heart beats is you have an impulse being sent from something called the sinoatrial node, right at the top right of your heart, down into the rest of your heart, around and back. But that impulse travels out to the rest of your body too, which means we can capture it and analyze it. If you've ever had an ECG done before, an electrocardiogram, this is exactly what's happening there. We're capturing the impulses from your heart and analyzing them, turning them into squiggles which we can then interpret. We put some extra ones around the side of your heart to see lots of different angles, to see when something is going on in a specific part of your heart too. So in this case, we've got a debug trace of our patient's heart, and it looks a little bit like this. You've almost certainly seen these squiggles before, on TV, in films, but you've probably just seen them as a flat line or as some random squiggles somewhere on a chart. You probably haven't seen the actual printouts that we get. This is a slightly smaller version of the actual printout. And just like any debugging, the skill here is interpreting the output. Does anybody want to make a guess at what this output might suggest? That's an entirely valid answer for a technology conference. I wasn't expecting anyone to. And the actual answer is lots of different things, right? This could, for one person, be a completely normal heart trace, because we are all really varied. In a different person, we might be thinking a little bit about what's going on here, or here, where we've got what we call tall T waves, after our main heart contracting, where our heart would normally relax. This can be a sign of lots of other different problems going on, in particular problems of your electrolyte balance. And again, there's no guarantee, this is not an exact science, it all depends on the context of your patient. But it might also prompt us to think back to our primary survey, because there's a few extra letters that sometimes get added to our primary survey when people talk through what to do. Sometimes people will stick on the end an F and a G, because people will say the DEFG in the primary survey stands for don't ever forget glucose. And that's because your glucose is a really, really important measure of your function. It's really, really important to regulate. And it's really, really easy to get wrong. If you're someone who's diabetic, you already know that probably from bitter personal experience. If you've ever seen someone who's diabetic, you're probably already aware that they have to be constantly testing their sugars. Lots of people now have CGMs doing that nice and easy. So we want to test our patient's glucose. Now, in a perfect world, what we would find is that this patient has a low blood sugar, because a patient with a low blood sugar is really easy to fix. I love a patient with a low blood sugar, because if they're awake, you feed them toast. And then they wake up and everything is fine. If they're not awake, you have to be a bit more of a faff with them. Unfortunately, when we test our patient's blood sugar, we don't find that. So a normal blood sugar should be somewhere between 4 to 8 millimoles per litre-ish. It depends a little bit. This is not an exact science. If you're diabetic, you already know your sugar range best. Anyway, we find a blood sugar of 15.6. Now that's too high. We don't like that. For the vast majority of people, that is going to be too high. So we can do another thing then. We can look at something called ketone bodies. Now, ketone bodies are produced by your body when it's not happy with your glucose balance. A normal amount of ketones would be less than 0.6. That's not good. But it does mean we've identified what could be a problem. Now, in real life, obviously, you can't exclude that someone has multiple problems, because people have this really terrible habit of having more than one thing wrong with them. And I really wish they'd stop, because it makes my life hard. But for the time being, we found a problem, and we want to do something about it. But we can actually collect a lot of these things together into a broader syndrome. So we know we've got shock. We know that we've got a fast heart rate. We know that we've got deep, fast breathing. And that's actually called Kussmaul breathing, if you want to look it up. We know that we've got an altered mental status, a high blood sugar, and a high blood ketones. And these are all signs of a single condition. That single condition is something called diabetic ketoacidosis, or DKA. There are two bits missing from this picture. And they're the bits which cause the hypervolemia involved. Because we've got lots of water through repeatedly peeing it out, and lots of thirst from all the water that you're peeing out. So this patient's probably lost a lot of water, is in diabetic ketoacidosis and has an altered mental status from that, and as a consequence is hypovolemic, has that fast heart rate, is shocked. So we know we've got hyperglycemia, we've definitely confirmed that. We don't technically know we have an acidosis, but we can be moderately confident that we might do. Likewise, we don't technically know for sure that we have a hypervolemia, but we can be relatively confident that we might do. And we're still at risk, even on top of all of that, of developing cardiogenic shock, because we might have an electrolyte imbalance going on. So all in all, this isn't a great day. Lisa's not having much fun here. But now we know what the problem is, so we can do something to fix it. And what we're going to do is we're going to go back to our primary survey. We're going to take our systematic approach again. We know that we didn't have a problem with our catastrophic bleeding, and hopefully, unless we've done something very, very wrong, our patient is not suddenly going to have started catastrophically bleeding. If they have, I think we should be asking ourselves questions as to how they got there. Our airway, on the other hand, that can change. That's really easy to change, especially in a patient with altered mental status. So we're going to have to keep a really close eye on that. If it does change, if they're no longer able to tolerate their own airway maintaining, we might need to put an airway adjunct in them to help things out. So we can put a tube in your nose or down your throat to help you breathe if you can't secure your own airway. Likewise, if you're not breathing adequately for yourself, we can use one of these devices called a bag valve mask to help get some extra air into your lungs, basically. On the circulation side of things, we know that we've potentially got a hypervolemia here. So we're going to be wanting to put a little needle in your arm, a cannula. And through that needle, we will pop some good old salty pasta water, which technically speaking is 0.9% sodium chloride. It's salty pasta water. It's literally, there is no difference. The rest of this, actually, is hopefully going to be a question of time and monitoring for this patient. There will be some more bits that we'll do when we get to hospital, but right now we need to get to hospital. Sometimes the best medicine is diesel. So we're going to pick this patient up If you had an ambulance out before for someone who can't move for themselves, you might have seen one of these before. That's called a scoop stretcher. And it's one of the things that we really commonly use to try and get someone out of a position where they're stuck. We're going to scoop our patient up on our scoop stretcher. We're going to get them into our ambulance, and we're going to get them into hospital. And in hospital, they're going to continue doing the same things that we've been doing. They're going to be giving some more of that cold, salty pasta water. They're going to be doing some monitoring. They'll probably add some insulin as well to help try and regulate that sugar balance. And they might need to replace glucose and potassium as they do so, because the sugar balance is really fine, and technically, this whole thing actually really is a low potassium state that masquerades as a high potassium state. It's complicated. But the important thing is, we've got Lisa to hospital. You've got her into a position where she's been saved. We've done the job. I hope, if nothing else, what I've convinced you of here is that although there's a lot of knowledge, there's lots of facts to draw on here, the process is not that complicated. I was a software engineer. I still work occasionally as a software engineer. But I'm just about to finish a master's in Paramedic Science. I should hopefully get my qualification on Thursday, touch wood. And in the process of doing that, lots of people have come up to me and said, oh, those things seem completely unrelated. What the hell are you doing? And oftentimes, actually, I have to convince them that really, it's not that different. You've got a much bigger knowledge base. You've got a much broader set of stuff about the human body. But the process of breaking down a problem into its component parts, identifying causes, thinking of what could go wrong, and then finding out what's gone wrong and treating it, is the same as debugging. We just happen to be debugging humans rather than computers. So if you take nothing else away from this talk, I hope what I've been able to tell you is that if you can fix a board, then you can fix a bike. And if you can fix a bike, then you can fix a computer. And if you can fix a computer, you actually have a pretty decent start at managing to fix a person. All you need to learn how to do is fill out the paperwork afterwards. Thank you so much for listening. Feel free to come and chat in the Q&A tent. If this has inspired you, there is a QR code there to find out how you can volunteer with Sunderland Ambulance. They have not sponsored this talk. I'm doing this of my own accord, but they are how I came into medicine, and I'm incredibly grateful to them as a consequence. So if you're interested, feel free to scan it.